Hello friends, hope you all are doing great. This is our part 2B discussion about athletic groin pain. Those who are new, we have discussed athletic groin pain in last two videos, part 1 and part 2A. My name is Anuradha Rakhunde Khamkar. I am a sports physiotherapist. I was working with BCCI, IPL, National Cricket Academy. I was working with Mumbai Cricket Association as well. I was assistant physiotherapy at Pace Bowling Foundation. Currently, I am working as a consultant physiotherapy at Optimal Performance, and I am a founder of Aspire Physiotherapy and Sports Center. Today's topic, we're gonna cover three topics: MPCA, that is Modified Progressive Copenhagen Adduction exercises. Then we are going to discuss clinical decision making process overview and factors affecting it. And last, my favorite topic is return to sports decision. Now MPCA, Modified Progressive Copenhagen Adduction. Copenhagen is the name of city. The city is situated in Denmark. It's a happy city, very well developed and balanced life. It is famous for that. So let's get back to our discussion. So MPCA program, it incorporates 6 progressive levels specifically designed for this study. Started from assisted isometric adduction hold, that is very mild kind of exercises, to full Copenhagen exercises, that is level 6. We are going to see all the levels and we are going to discuss each and every level. Level 1 is submaximal isometric contraction, and it is having the lowest post exercise muscle soreness and rate of perceived exertion. So you can utilize this rehab program when athlete is participating in sports in controlled manner, because many times what happens when we when we are doing rehab with athletes, with all the rehab load, athlete gets lot of soreness or post exercise DOMS, which makes him or her impossible to participate in any kind of sports activity. So this exercise will help us to modify that or to control that. Okay, this is over this program is over a 8-week period. Participant completed 2 sessions per week with difficulty and the volume progression incrementally. I have done this. We are going to discuss each and every picture. This is the YouTube link which is showing last progression. Okay, not all these things. So we are going to discuss all these things. So if you see in picture 1, if you compare every box, height of this first box is less. Okay, second, third, and they have increased in 5th and 6th. And if you see the support, leg is supported from knee. Okay, and the other leg is also taking support from gown. So this is like lifting a pelvis little bit, hold it and then relax. In picture B, you can see knee is not supported. Okay, in picture C, if you see, as compared to picture B, you have plinth support till knee. So this is a short lever exercises which will take less stress on the adductor, as compared to this where patient is getting support from ankle and not above that. So this is long lever exercise. It takes a lot of effort to finish this as compared to knee support. Then if you compare this with picture D, you can compare height of plinth as compared to C. The height of block or plinth has increased. Same thing, ankle support, and they have lifted knee. So there is no other leg support. In picture E, you can see definitely height of bench has increased, and in fact athletes distance from ground has also increased. So lot of effort and lot of stress on your adductor muscle. And the last picture is complete original Copenhagen exercise. It's with physiotherapist or your partner. Okay, so you can see the progression. this is all explaining the same thing, level 1 to level 6. You can see the sets and repetitions. Target 1 week 1, 2, 3 sessions, how many sessions they have done. Sets per side, they have utilized both the sides. Repetitions 6 to 8, you can see. Time under tension is the hold period 20 seconds, and total time under tension they have calculated with each repetitions into complete repetitions, and that's how they have leveled it. Okay, so whenever you are prescribing rehab program, you have to prescribe everything, not just exercise and repetitions. How many times hold, how many repetitions, how many sets, how many sessions per week, everything. What was the result? There was statistically significant increase in eccentric hip adduction. Okay, so EHAD is eccentric hip adduction strength and eccentric hip abduction strength. So there was increase in both the strength, and that is why increase ratio. So when you have increased ratio, that means they balance out each other. We always focus on hip abduction, we never focus on hip adduction strengthening, and that is also one of the reason why we get a lot of groin injuries, because you have a strong hip, and when you do running and change, basically the moment in which you are changing direction frequently and very swiftly or fast, that time your adductor muscle is unable to balance out your glute muscle strength, and that is how it get injured. So this exercise help us to work in this factor. So you can utilize this exercise as a rehab program, you can utilize this as a prehab program as well. Okay, so conclusion is 8-week MPCA exercise elicits significant eccentric hip abduction and eccentric hip adduction strength increase with reduced level of muscle soreness, which is add-on. So patient is not getting soreness as well, so they can participate if they are performing this as a prehab exercises. Now next is mechano-biological descriptors of resistance exercise stimuli. So whenever we are giving any particular, now resistance exercise, that means a normal strengthening exercise. See, strength is one part, we target on a different part, strength, hypertrophy, everything. But whenever we are discussing about the resistance exercise, what all structure you have to keep in your mind when you are designing a rehab program. First is load magnitude, how much load you are putting that particular muscle. Then number of reps and set, rest in between sets, how many seconds, how many minutes between the repetitions, between the sets, duration of every session, number of exercises per session per day, how many exercises you're gonna give, 5 exercises or 2 sessions of each 3 exercises, that makes a lot of difference. Violational muscular failure is like, see, everyone is having different mindset. Few people will tell you that they have reached their fatigue at 3rd set, few will tell no, I can go on till 6th or 7th. So you have to particularly design it according to that person's mental strength. You will get that idea within 1 or 2 sessions how much you can push that athlete per session. Range of motion, which range of motion you working. Time under tension, particular muscle is under tension for how long, because you have to think about it. I have seen many people doing absent-mindedly all the hold isometric exercises. At the end of 2-3 different exercises, patient is really exhausted. So you have to make clear, you can't keep going on one particular exercise. Contraction type, isometric, isotonic, eccentric, concentric, you have to manipulate with that also, which kind of exercise you will prescribe first. Why? Always think why you're giving this exercise, why this kind of contraction. Level of pain acceptance, everyone is having different pain tolerance capacity, so you have to modify it according to your athlete. Okay, few people will have more tolerance, few people will have less tolerance, they will take more time to rehab or recover with the same kind of injury. This is the pictorial presentation. This is kind of an engineer stuff. I will try to explain it. So this is the exercise stimuli. How much exercise? So this is mechano-biological exercise stimuli. Why they said this? There are mechanical factors, there are biological factors, because we are putting stress on a living tissue. Okay. What all factors will affect it? Genotype, age, gender, muscular architecture, muscular subsystem, which system you are hitting. I have seen many physiotherapists are not taking this into consideration. When you are strengthening a marathon runner and when you are strengthening a sprint runner, which system are you hitting when you are strengthening particular part? So which thing? Creatinine system, glycolysis system. So you have to modify your rehab program according to that. Then hormonal status, which athlete you are treating, male, female, old, diabetic. Nutritional status, immunological status, because this will affect if their immune system is not at this position to get all these things, they're not gonna respond according to your expectations. All this factor will affect, and then this adaptation will happen. This adaptation effect will show you as a response. So after you're giving them few sessions, you will get to see the adaptation and response. That could be gain in the strength, or that could be soreness or more fatigue. You have to manipulate your next rehab session according to their response, okay, and not according to the time frame or your expectations. So you have to be very sensitive about this. This is very beautiful slide and article. I will insist every physio go through and read this. Now the last topic, return to sports or return to run. Return to run is the biggest milestone according to me. I personally become very happy whenever my athlete achieve this, because then I can calculate there is no more time to return to sports. So why is running decision is so difficult? First, there is not simple A plus B is equal to C. Okay, there are n number of patho-anatomical structures involving in injury, that it is very difficult to predict that everything is healed and at what level it is healed. So there are large number of patho-anatomical conditions. There is usually more than one source of groin pain. And there are no clinical tests, gold standard. We don't have clinical tests to diagnose, this test is, if this test is negative, then athlete can run. We don't have that simple calculation here. And radiological finding do not, correlate with the healing. So if you get an MRI just after the injury, and then you get an MRI after 4 months of rehab, there is, if at all there is a change in MRI finding, you cannot give them short assurance that there is a change, it's healed, now it will not give you any pain. Okay, there is no such guarantee. Third thing is, it is difficult to decide if running is contraindicated, because running is, it's not just a testing of adductor, but there are n number of stuff like insufficient core stability can put more stress on recently healed groin, which can again give pain, and you will keep thinking like, I have given my best rehab and still my athlete is having pain. Then insufficient strength in single leg stance, insufficient hip flexor function, increased tone in adductor longus, psoas, tensor fascia lata, anterior gluteus medius, etc., and decreased range of motion at the hip joint. So whenever you are giving your rehab, you have to calculate all this structure as well, and you have to simultaneously work on all this thing. Because see, you can't say that athlete has come for groin injury and I will focus on groin injury, because what is their goal? The goal is not to be pain free at groin. Their goal is to return to sports, so they have to run, and one injury can expose the other weak link as well. You have to diagnose everything and you have to treat that. The groin pain provocative test used in the running decision, this is what I will practice when I have to take a decision. First, walking and dynamic warm-up test, squeeze test, resisted hip adduction test, and pubic stress test. These 3-4 tests will give me idea about return to sports. So those who are working with association or academies, because they have panel, okay, and everyone has to sit and decide whether the athlete is ready to return to sports or not. I think this will help you to give everyone idea, this test I have done and this is the report. So as a warm up, what you will do, 10-minute warm up, 50-meter slow jog with walk written, and 20-meter shuttle facilitated running tall style. You can include butt kicks, high knees, jog backward, skipping, and sideways shuttle. Now whenever I am seeing squeeze test, you can use it as a litmus test. Okay, so these 3 different positions, you can go through all the explanation, clinical guidelines, and how to calculate P1. I will suggest you to go through Aspitar article and download that and keep reading and practicing it, because you are not gonna remember everything with this presentation only. You have to practice it. Okay, and if I keep explaining, this lecture will go for like forever. Next is resisted hip adduction test. Athlete is in a modified Thomas test. See the hand positioning, see athlete how they are standing, their base of support. Athlete's non-involved leg is on the therapist, and ask athlete to do adduction. Okay, and ask them, if you have a dynamometer, you can use it without instead of hand, and ask them to compare with their usual associated pain. I have seen many athletes making this mistake, that they will ask, how is the pain? Now they don't know which pain they have to compare. Okay, so majority of them is like, after running session they have developed some other kind of pain or some other site of pain. So you have to compare and ask them what you are asking, and repeat the test on other side. Always repeat it on the other side, because sometimes they have some unidentified pain at particular area and the both leg. So you have to compare that, like what kind of pain you are trying to elicit it and what kind of pain athlete is actually experiencing, and both of you are in this on the same page. Sideline bridge test. This is similar to what we have seen in Copenhagen test. So athlete is in sideline, support till ankle, and ask athlete to lift their pelvis, hold it and then relax and compare their pain. Okay, so this indicates that they can commence or continue running. So these all tests, it is not just to decide whether they can start running, but how long they can continue, what will be the intensity, when you can start adding the repetitions or intensity, you can increase the intensity of running. So these all tests will give you idea from actually being pain free, then again a little bit of soreness, and when athlete is again recovering and ready to run their next session. Last test is pubic stress test. See, the non-involved leg is not completely bent. Okay, it is resting on therapist, and what therapist is doing, they are doing extension and abduction of the involved side, and ask athlete for any discomfort and pain. Now they are adding 2 stuff, extension and abduction. So if pain on passive hip extension, it gives a caution with the straight line running. So athlete will complain you that when I run straight, I don't have pain. But when I change or try to change the direction and run crisscross or sideways, I get pain. So in that case, what will be more painful? Passive hip abduction. Okay, so you can check both of this thing. And if patient is saying, I don't have pain in hip extension but I have pain in hip abduction, so you have to inform athlete that you can run but in a straight line, and you should not commence change in direction, and ask them to continue with few time, and then again check with this if hip abduction pain is also reduced or they don't have any pain, and then you can clear them for further change in direction, and other crisscross running activities or drills. Okay, so this slide compares everything. Red flags if they are having pain on every test. Yellow flags, so yellow flags is like, yeah, if after a running session or what you say, before commencing the running session, athlete is having this pain, so that is like yellow light. So you can do few more rehab sessions and then again check for readiness of the running. And green light means athlete is ready to run and they can commence their running activities. The squeeze test, I told you the squeeze test is a litmus test. So how it is, after first day of running, there is a significant drop in P1. How to calculate P1? You can go through the previous slide, go through that article and calculate. This is not a spoon feeding. I am just, giving you tools. So you can use this in your clinical practice. Okay, so if there is a significant drop in P1, day 2, so before treatment or before running, they are partially recovered, because sometimes you just have to give them some time. Today they have run, they will complain some pain, but the pain is very less as compared to their previous pain. And then next morning before the running session, they will come to you, you check all these tests and there is partial recovery. And after you giving them treatment, they're almost full recover. You can ask them to run again. Okay. Now second running session. Again you check after running session, significantly drop in P1, partial recovery next day and full recovery after your treatment. They can repeat run and they can add repetitions if okay. And third session, same thing, after run there is no change, drop is there. Day 2, next day, they are fully recovered as compared to the previous sessions. And after treatment, there is no change because they are already fully recovered. So you can increase the repetitions, you can increase the intensity, you can increase the duration which they are running. Okay, so that way you have to, it's a permutation combination, run, reduce, see their response to this previously discussed 4 tests and then allow them. These are my references. You can, everything is free on Google, free to download PDF, read, go through it. If you have any doubt, you can always comment and ask me. Center. Today's topic, we're gonna cover 3 topics. MPCA, that is Modified Progressive Copenhagen Adduction exercises. Then we are going to discuss clinical decision making process overview and factors affecting it. And last, my favorite topic is written to sports decision. I have done this, we are going to discuss each and every picture.